so
Awesome.
much, Omar. How are you?
I'm doing wonderful. How about you?
Good, man. Good. It's a really a real pleasure. It's a big honor to have you in Dentistry Channel.
Thank you.
Uh,
Thank you so
for me,
much.
it's a real big honor. I checked your presentation twice, and I think that you're a great speaker. You're opinion
Thank you.
leader that are very knowledgeable in digital dentistry. You manage it perfectly, and I think you're of the most talented persons, especially on communicating everything you know. So I've got like some notes, but I want to start by not only thanking Dr. Sam Omar from Egypt, Cairo, but also please I'm gonna let you introduce yourself to speak with the audience and tell a little bit about yourself, your life, yourself. You know how you travel around the world and how you end up who you are right now.
Thank you so much, Nico. Well, first of all, I would like to start with thanking you for this invitation. It's truly an honor to work with you, and it was an honor for me first to meet you. I think it was about a year and a half ago. We met the
Yes,
first time in Poland,
that's right.
and it was truly an incredible experience. And then we clicked, how people click.
That's right.
So I have massive respect to you, Nico, and I'm super happy to contribute to this beautiful project. And the way you introduced me is actually, too much for me. I'm not that important or anything. So much, thank you so much for that.
And you brought so many good things whenever when I met you, and I feel the same way as you feel. We just clicked, and I still remember that drink that we had on the bar. Uh,
Absolutely.
we spoke about so many things, and
Absolutely.
it was a great honor to get to know you and becoming a friend and being able to count on a person like you. It's a really big honor for me, for Dentistry Channel, my platform,
Thank you so much.
my bet, and thank you, really thank you. So Sam Omar, please uh, let everybody know who you are.
Awesome, we'll do that. So I'm a full-time clinician. Well, I practice here in Egypt. Right now, I'm actually practicing in multiple offices. So I'm a general dentist until now. But besides being a general dentist, I'm just extremely passionate about digital dentistry and implantology, especially. So I've been basically doing implants primarily. I love doing everything when it comes to implants. I love doing the whole workflow, starting the planning, the manufacturing of the guides, the prosthetics. I enjoy doing the lab work. I love doing the surgeries and I love doing the prosthetics. So, being a general dentist actually broadens your horizon when it comes to what is it exactly you'd like to do. Because now, because I'm a general dentist, I could actually do everything. Besides this, I'm also involved in the development of the R2Gate and digital oral design software with the team back in Korea, with Dr. JC Kim, who's my mentor and who's basically the person responsible for everything I know. I owe him absolutely everything that I know. He's my mentor, he's my teacher, he's my older brother. So I learned so much from him. We share the stage basically every month before the current circumstances. We used to go to Germany every month. We lecture together on digital oral design and R2Gate. And again, I love what I do, and that's basically what I enjoyed sharing the lecture that I shared in your platform, Nico. And I'm really happy to have this conversation with you afterwards.
Thank you. I can tell that Sam Omar loves what he does because the passion, with what the way he speaks, how he communicates, he talks about digital dentistry. It's amazing. And I remember that even though I've been using partially the digital dentistry, and if I haven't done it like completely, it's because so many like expenses. Everybody speaks about, like recently I was speaking with Andrea and Alessandro Mastrosa. They are part of the digital dentistry, digital dental revolution. They actually have studio design in Modena. And I was asking them, what would you tell to a very recent graduated in dentistry? How would you convince them that actually turning into digital, it's the step to go, because our generation learned from, you know, from the beginning, like everything was not digital, everything was analogic, and we were using impressions and silicons and all these kind of things, and everything has turned into digital, and a lot of investment needs to be done as well, right? So dentistry has been always very expensive, and now it looks like everything is more expensive. But then people like you shows us how you can actually become more efficient, right? And you can optimize your resources much more if you turn it into digital than if you stay blocked into the past. Because at the end, you're going to consume less time in the chair side works by using digital dentistry. And this is something that every time that I do an immediate loading provisional over my implants, I realize I spend so much time in the chair just trying to adapt that provisional on the top of my implant with the specific abutment and all these kind of things. And I would love to have something already in my hands that I can just plug on the top of my implant that has been
100%.
pre-guided and pre-prosthetically designed, that I can put it. So you reduce time, you reduce stress. So one of the things that impressed me the most when I got to know you was the easy way that you communicate this. And this is the reason why this amazing presentation that you share with us in Dental Surgery Channel is going to bring so much information to the people. And I've got a few questions about the presentation, because this is going to be like a premiere or a preview, right? You talk about a concept that I learned from you, because you have the trademark, which is the 5-dimensional concept that actually Dr. Irfan Abbas told me about. And he collaborates also in Dentistry Channel. He mentions you on this 5-dimensional concept. And I'd like you to introduce a little bit that concept to the people, because this is linked into the Artigate bone density assessment to warranty that primary stability of your
100%.
implants. So why don't you speak a little bit about that in a summarized, you know, in a way that people can understand that?
Absolutely. So let me tell you briefly the idea behind the 5 dimensions of treatment planning. Well, the way this started is actually before I even placed my first implant. I used to work as a professional treatment planner. So I used to sit on a computer, receive the CBCT, receive the models from dentists, and I used to plan the cases for them and then review the cases with them online. And that's before I became a full-time clinician. So because I used to see hundreds of CBCTs and per week, and I saw so many cases, I found that there was a pattern for us. Whenever we're designing a case, you have to go through a pattern. And what I saw was, whenever you're positioning an implant, it's better to look at this procedure from 5 dimensions. So we call this the 5 dimensions of treatment planning. So the first 4 dimensions can be done with any software, because it's a matter of dragging and moving the implant. You have to know, how much bone you need on the buccal, how much bone you need on the palatal, what is the distance that you keep between the 2 implants, what is the relationship of the implant to the adjacent teeth, how deep should my implant be, and all that stuff is actually quite basic. And then we found that there was what we call the missing dimension of treatment planning. I always call it the missing dimension, which is dimension number 5, which is bone density. Because a lot of softwares out there give you an idea about everything else with the 4 dimensions of treatment planning, with the exception of the last dimension, which is the bone density. The only software that I saw solve this issue for me was actually Artigate, because you could do all the planning you need, but because we don't really have enough information when it comes to the density of the bone, we're just depending on our gut whenever we're doing surgery. And also, the one missing element is that when we're doing guided surgery, you somehow lose a little bit that tactile sensation that you get with your hands. So it's really difficult for us to actually know what the bone density is. So the 5 dimensions, they're called the 5 dimensions of treatment plan. And I think that knowing the bone density is also a part of the treatment plan. This is an extremely important part when it comes to planning, because again, you might do everything perfectly, but because you don't know how many drills you need to use, you lose the primary stability of the implant, and you lose the ultimate goal, which is providing the patient with a temper. So that's the idea. So it's a whole workflow that we need to go through with specific focus on the positioning of the implant and specific focus on how many drills you need to use, because eventually what we say is patients want teeth and not implants. So we need to always bear this in mind. And the best thing to do is to provide the patients with the provisionals by going through the whole workflow correctly.
Beautiful, beautiful. Because as we were saying before, so much time invested on the chair side versus prefabricated restoration is something that also just blinds my mind amazingly, because you already receive not only the surgical guide that you're going to use during your surgery, but you're also receiving the prosthetics, the crown or the bridge that you're going to use on the top of your implant, which is something amazing. Sometimes I remember speaking with Sam Lee, and he told me once, sometimes I open the sinus so easy with the Mila kit, and I do my sinus lift so easy that I need to justify what I'm charging to the patient by doing something slower, because otherwise, you know, the patient is going to go like, oh, that's it. And you're going to charge me all this because of just like
100%.
surgery and prosthetics.
Absolutely.
It's amazing, right? So
Absolutely.
yeah,
Absolutely.
so when we were speaking about like those, you know, those new students and those new like graduated dentists that are stepping on the jungle already, and they're going to start like fighting with each other, and they're going to, you know, try to provide the best dentistry. What would you tell them when you see these, you know, two worlds that look parallel, look similar, but they're not the same until you realize that they're completely different?
Definitely. You know, I'll answer your question in two parts. So the first part is, how do you really justify, you know, if we're doing the provisionals before the surgery and everything is being done guided, so it takes much less time. You know, the key is for you to explain to the patient what the value that they're getting basically is. So what I do right now is I do a PowerPoint presentation for every patient before I do the surgery. So I do the planning always in front of my patients. And the key is you're trying to show them the value of what you're doing. So basically, if I do this case freehand, for instance, it might take me more time, and that might justify the price. But I tell them that normally it takes me this amount of time, but I'm doing it guided. So this, you know, that takes a little bit of time when it comes to here. And I'm doing what we call a prefabricated prosthetic. And before, you know, before I used to do a chair side reline. And eventually I tell them what the challenges that we have are. And then eventually I'll tell them how, you know, digital solves this problem and how it gives us more value. And people only appreciate things when they understand their value. So you might do the same service for two patients, but if you explain it to this patient, he'll say that this dentist was excellent. He did everything really fast with high technology. On the other hand, he'll say that maybe, you know, he's ripping me off. He did it really fast, you know, but it's just, as you said, it's just a matter of communicating what you want to communicate to the patient. That's, you know, when it comes to the first part. The second part is, what do I say to students that are just graduating right now? Well, those are the people that we really, really, really want to, you know, we want to try and help them and guide them as much as we can. Unfortunately, in dental schools, there isn't much information when it comes to digital dentistry. It's not really in the curriculum. So what you'll find is dentists graduate not knowing much about digital dentistry. On the other hand, technicians know way more about digital, you know, than actual dentists. So what I believe we should go through is, I think there should be a part when it comes to digital dentistry that should be incorporated in our curriculum. But again, this is you know, a little bit tough. We'll have to go through a lot of routine and a lot of red tape, so that might not be very easy. But the thing is, people need to open their minds to two things. Number one, you have to open your mind to, even though you're a dentist, I suggest you go spend some time in a lab. And I believe spending time in a lab, for me personally, was one of the most, you know, important things and one of the best learning experiences I've ever had in my life. Certain things you will only understand if you're in a lab, because in a lab, especially a digital lab, because there you see how digital is being done properly, and you understand the input and what is being done with your input. So that's the first thing that I recommend. The second thing is, which is when it comes to the logistics and the cost and everything. Of course, owning a scanner is very expensive. Of course, owning a milling machine is very expensive. On the other hand, what I believe also would serve graduate dentists that are recently graduated is a group practice. A group practice is one of the best things you could do to yourself. I think if you're gaining knowledge by 10% per year, if you're practicing on your own, I promise you this will be double minimum if you practice in a group practice.
Right.
So now you're solving the issue of the logistics and the money and all that and the price of the equipment while having, and that's of course with a good team. So if you practice within a good team. And certain things when it comes to digital dentistry are not very expensive. Like for instance, a 3D printer. Here in my office, right next to me, I have two printers, less than $500. It's very, it's extremely simple. It's extremely simple to use. There is a learning curve, but it's not too steep. So just people need to open their mind to the fact that digital is not expensive. Certain tools are expensive, but again, we can solve this issue by, starting a group practice. These are things that we can start with. So these are, basically my advices to everyone who's just graduating right now.
That's a great and very important information for all these people that are, starting to learn the real life of a dentist, which is becoming, even in a COVID situation, very complicated, and it's becoming very stressful. You were changing a little bit the subject. You were talking about the Apex Guide, and I have here mentioned the Apex Guide. I don't remember. I still don't remember very well what was it about, but I have it here highlighted. Apex Guide. Interesting.
Very, very nice. So let me tell you exactly why we came up with this. So right now, I think we can all agree that with the current research and with the current literature that we have, and with the histological studies that we saw, is that basically partial extraction therapy is becoming the gold standard when it comes to immediate implant placement. And because I'm a firm believer in digital dentistry and in guided surgery, and I believe that everything, as much as possible, should be done guided, that's exactly why I believe we should actually try and do a procedure like socket shield and try to do it guided. So that was the reason. So why is it called Apex Guide? So I spent some time with Howard Glockman, who's a friend of both you and I, and he's definitely one of the best surgeons out there. And what he always said to me was that the most challenging part when it comes to partial extraction therapy is actually hitting the apex. So when I thought about this, if we could do that part guided, and if I can design a surgical guide that is a very simple guide that helps me reach the apex, that's basically all I want. From there, doing a horizontal split is a very easy thing. So that was basically the idea behind the Apex Guide. So in R2Gate software, what we do is we calculate exactly what is the length of the root, and then Megagen offers their kit, which is the root membrane kit. So there is the first drill in this kit, which is a Gates spider drill. So the idea behind it is I use that Apex Guide, and I use that drill, and I transfer that drill from being a non-guided to a guided drill that helps me reach all the way up to the apex. Once I do that, all I need to do is I need to do a horizontal split, and then I can remove the palatal portion, and I can continue everything from there to finish the shield and so on. So that was basically the idea behind the Apex Guide.
That's very interesting. That's very interesting because you talk about a lot of things in the presentation, in your presentation, not only about like specific things, but also you introduce as well the partial extraction therapy case, including to the digital. So you're like squeezing digital possibilities and chances that you have today. Right. That actually sky's the limit, as it is said, right?
Absolutely.
Absolutely. It's very interesting when you put in front guided surgery versus guided prosthetics, and this is something also that people should know about. One thing is guided surgery, and the other one is guided prosthetics. I still remember when we started with Nobel Clinician and Nobel Guide, and I received like the software, and I bought the software, and everything was about just guiding in the beginning, like guiding everything like flapless and putting a punch and placing the implants, and then you will do something with prosthesis. But there was not a guided prosthetics. It was just guided surgery. So wherever you had the bone, even though it was like hugely resorbed, if you could place the implants, you would place the implants. And at the end, you would end up with a very deficient reach at the most crestal aspect with the implants in place, with no flapless technique, non-elevation of the periosteum, but at some point you would have like that typical bone resorption, that peri-implant resorption, because at that point maybe we would need to regenerate or something. And it was like considered that it was just a surgical guide that was used to just guide the implants into the bone. That's it, where the bone was, where there were the implants. But today we are, what you said patients want teeth, they don't want implants. So you're responsible for the implant, but they want the teeth, and that connection needs to last forever for them because they want everything to last forever.
Exactly.
So, Gordon, please tell us a little bit about this confrontation between like guided surgery and guided prosthetics in your concept, please.
Definitely. You know, one of the issues that we had with, and that's one of the reasons basically why guided surgery is not widely adopted right now, because you know, if you see the percentages of people that are doing freehand surgery versus guided surgery, it's a very big difference. And I think less than 10% of implants are actually being done guided, even less than that. And some people have a different answer to this. Some people will talk about, you know, the fact that they cannot use digital technology. So for them, this is unattainable. Some people will say that it's about the cost of the guide, but we solved this problem with having doing everything chairside right now that dramatically decreases the cost. And the third thing is, some people say, I'm just too good to use a guide. And that's, you know, one of the things that we definitely face. So now my answer and the idea behind guided prosthetics is to answer those that are saying that I'm too good with surgery or I don't need a guide. It's a very simple case, for instance. Well, the thing is, I'm always aiming to give my patient a provisional prosthetic. And we always know that this prefabricated provisional only fits in one position, because I need to place the implant in a certain position. This is the only position where the prosthetic will fit. So essentially what I'm doing is, it's not a matter of how easy the surgery is. Even if the ridge is this wide, that doesn't really matter, but the prosthetic fits in only one position. So what you're doing is you're guiding the prosthetics in the right position by guiding the implant. And that's what changes our mind completely from the fact that it's a matter of surgery. It's actually now a matter of the prosthetic part. So we're trying to facilitate the process of delivering the prosthetic by calling it guided prosthetics. That's basically the concept behind it. We want to move away from the word guided surgery and start to think more about guided prosthetics.
That's really, really interesting. That's the point of using today digital dentistry. If we are talking about the digital workflow, let's say, for example, that I don't have a scanner, but I want to start my surgery, and I have, for example, premolar, first premolar, and I want to place it post extraction, and I want to have that option of immediate extraction, immediate implant placement, immediate loading. Which would be your steps if, let's say, someone is located in whatever, in Munich or in Berlin or in Rome? How would you start if you don't have a scanner? Which would be the digital option that you have? If you don't want to invest in a scanner, but you want to receive that surgical guide with the surgical prosthetics, with the prosthetics included.
Beautiful. That's a really nice question. Well, and the reason why you asked this question is because we all know that not everybody has a scanner, and that's, you know, something that we all know. I myself only had a scanner actually about a year ago. So, you know, as people might think, no, I've been having a scanner for a really long time, but that's actually not the case. But I've been practicing digital dentistry for almost 5 years now. So what we want to say is the input and when it comes to guided surgery or guided prosthetics is always the same. The idea is I need a CBCT and I also need a model. It doesn't really matter how you get the model because eventually it will be digitized. So if you take a normal impression, you'll send that to the lab like I did, you know, for a really long time. They scan the model, they send you back the STL file, and then you can start your planning from there. If you have a scanner, You just, you cut the middleman, as we say. It's just a little bit faster. But again, doing guided surgery and guided prosthetics doesn't have to do anything with having a scanner. It's just a method that makes your life a little bit easier. And having a scanner does not make you a digital dentist. It's just the way you practice your cases, the way you plan your cases is what makes you a digital dentist, regardless of the armamentarium and the tools that you have.
Right. Right. Okay. So in this case, for example, you would send a cast model with impression to the lab, so the lab would scan it and also CBCT, and then they send it to a manufacturer of the guide, and also the manufacturer of the prosthetics.
Yes. So basically, when it comes to digital dentistry, there are two schools: either the DIY, do it yourself, or send it to the service center. So for instance, let's talk about R2Gate. I myself try to do everything myself. So I receive the data, and once I receive the data, for instance, the CBCT and the model scan, whether it was an intraoral scan or a model or an impression that I took, sent to the lab, and they send me back the STL file, and then I do my own planning. But that's Sam Omar. This is how he likes to do it. Let's say if you're a busier clinician, your practice is really busy, or you don't have the time to actually do that yourself. It's also very easy because the input is exactly the same, the CBCT and the STL file. The only difference in this case, if you want to use R2Gate, send it to one of the R2 centers worldwide. In Spain, we have an R2 center. In Europe, in so many different countries, we have 124 labs worldwide that are actually providing the service. You could choose whichever lab that is closest to you. You provide them with the information. If you want them to do the planning, they do the initial planning, they send it back to you, you check the planning, you adjust the planning as necessary, and then you sign it off and you send it back to them. They'll manufacture the guide for you. They'll design and manufacture the prosthesis for you and send it to you all in the same box.
Beautiful, beautiful. I've seen one of the last questions that I have, because I know that you're a busy man, and I know that I have a limited time. So one of the few questions, the last question that I have, you used Densa burrs, which is something very popular today in your case, in one of your cases you presented. How do you match the Densa burr with the guide and the R2Gate guide? Do you mention that you want to use that Densa burr, or at some point you just how do you make it match with the R2Gate, with the cylinder that you're going to?
That's also an excellent question. Well, in the case that I showed in the presentation, it was actually not done guided. It was template assisted. So basically, I did not do it fully guided. Okay. But because of this case, and because of a discussion that I had with a fellow dentist, who's Isaac Turio, by the way, I showed this case, and then he said, it would be really nice if we do, the integration between R2Gate and Versa completely guided. And I told him, you think I haven't thought of that?
Of course.
We actually, at the time, this was the inspiration to start to do something that is completely guided. So what we did was we developed extenders. These extenders are actually extenders that turn the normal Versa burrs into completely guided drills to be used specifically with the R2Gate kit. Okay. So the idea is, the cylinder part is the part that has the same dimensions as the surgical guide of R2Gate. And basically all you need to do is you need to attach the drill that you're using to the proper length of the implant that you're going to be using. These extenders will guide you to the right depth and will make sure that everything goes nice and guided through the cylinder. So that's basically was the idea behind it. And I think we've shared multiple cases using that in the R2Gate experts group on Facebook and on social media, and it shows the beautiful use of such kit. It's a really, really, really simple kit that helps you get the best of both worlds: osseodensification and guided.
That's beautiful. That's beautiful. And this is why I invited Sam Omar to Dentistry Channel, because I know that he's one of my best assets. He's one of my best opinion leaders. and I know that I have the best. And I have to be honest, and I have to tell you, I asked Dr. Kwambum Park, can you give me some doctor that actually is really experienced with Artigate that can contribute to Dental Surgery Channel? He didn't hesitate at all. He didn't even blink. You know, he said, you have to ask Sam Omar. So I think that it's very honorable that even our big mentor, Dr. Kwambum Park, mentioned you and suggested you to
massive honor.
and I'm really, really thankful to him. And I want to thank you personally. And I'm really looking forward to see you very soon, Sam Omar. I want to thank you. I hope that all the audience received so many tips and tricks out of your presentation and your interview. And I think that it's going to be very, very worth it to review it completely because the people are going to learn so much after this. And I think that secrets kept are not worth it. I think that experience and all the tips and tricks need to be shared. And sharing is what we should do all the time.
Sharing is caring.
That's right. That's right. So thank you, Sam Omar. Thank you for being in Dental Surgery Channel. When am I going to see you? When am I going to see you? When?
Hopefully very soon.
Yes, right. Yes. I hope so. I really hope so. I'm looking forward to see you very soon. And thanks again for your contribution. Thank you, Sam Omar.
Thank you so much, Nico. You know, it's really, really, really an honor for me to have this meeting with you and to be a part in a great platform that I'm honestly very proud to be in. I think you're doing a really good job. I know it's not very easy because I try to come up with educational material myself. I shoot videos and I know how much effort it actually takes to do that. So I'd like to thank you for coming up with a content that is it's actually really, really helpful content. And it's designed in a way that really, really serves you in the most intricate way and the most classic way. You know, you just show things in a really nice way, Nico. And you have a big talent when it comes to this. So I just want to thank you for your talent and the time that you're putting to put all of this together and all the effort that you're putting in. So thank you so much, Nico.
Thank you, Sam Omar. Thank you. Here you have great honor to have you with us, with me in Dental Surgery Channel. Thanks
so much. Thank you so much.
See you very, very soon.
See you soon.
See you, Captain.